Cirrhosis happens when there's buildup of scar tissue in the liver to the point where this scarring alters the liver's ability to function normally and puts people at risk of developing liver failure, liver cancer, and the need for a liver transplant. Although most people assume that cirrhosis only happens with people who drink a lot of alcohol, folks with any form of chronic liver disease are at risk of the development of cirrhosis. There are many different causes of chronic liver disease, which is estimated to affect almost 25% of the Canadian population. And although drinking large amounts of alcohol is a major cause of cirrhosis, other important causes include non-alcoholic fatty liver disease, which we refer to as NAFLD, viral hepatitis B and C, and autoimmune and genetic causes. Over the past decade, clinicians like myself who work in hepatology and gastroenterology have noticed an increase in the number of individuals who are developing cirrhosis and its complications. And so in response to this, our study team set out to explore how many individuals have cirrhosis in Ontario using ICS data from 1997 to 2016. And what we found was that rates of cirrhosis, both new and existing diagnoses, were increasing significantly across all age groups. We were most concerned about the steep rise in new diagnoses of cirrhosis among younger generations, particularly those born after 1980. In our initial work, it was unclear what chronic liver conditions were driving these trends, and we were not able to define the underlying cause. But with support from the American Association for the Study of Liver Disease Foundation, we wanted to further understand which chronic liver diseases were driving high rates of cirrhosis in Ontario and anticipate this population's need over the next 2 decades. This will help to support early identification and management of liver disease before cirrhosis develops. In order to do this, we initially needed to accurately define which underlying chronic liver conditions were leading to cirrhosis. First, we performed a study where, in collaboration with investigators from the University Health Network, we examined individual patient-level data from both Queen's University and the University of Toronto of people with all different types of chronic liver diseases and linked this with ICS data. By linking this data, we were able to determine with good accuracy if some developed cirrhosis from either alcohol-associated liver disease, hepatitis B or C, NAFLD, or other rare autoimmune or genetic causes. We also needed to account for the fact that the rise in cirrhosis disease may be because we have better testing for cirrhosis. What we found was that between 2000 and 2017, there were almost 160,000 new diagnoses of cirrhosis among individuals in Ontario, and that over the study period, this increased by 26%, with an average increase of 2% per year. The largest increase in new diagnoses of cirrhosis overall were for individuals with chronic hepatitis C, as well as non-alcoholic fatty liver disease. However, among those born after 1980, alcohol-associated liver disease and hepatitis C-related cirrhosis increased dramatically by 12% and 10% per year, respectively. When we use modeling to project the future rate of cirrhosis to the year 2040, under the assumption that there would be no changes in the way we identify or treat underlying chronic liver disease, we found that by 2040, cirrhosis incidence is projected to continue to increase by another 10%. Mostly driven by non-alcoholic fatty liver disease among postmenopausal women. NAFLD would be the cause of 75% of new cirrhosis diagnoses. Further, alcohol-associated liver disease will be responsible for a significant proportion of cirrhosis in those born after 1980. We were also able to show that with the availability of effective antiviral therapy for both chronic hepatitis B and C, that viral hepatitis will decline as a significant cause of cirrhosis in the future, with the exception of chronic hepatitis C cirrhosis among those born after 1980, where rates are projected to continue to rise as a consequence of the opioid epidemic in this age group. The results of our study imply that chronic liver disease and cirrhosis are going to continue to increase over the next 20 years. Therefore, Canada will need to be prepared for this, and we strongly support the need for the development of a national liver strategy. Our data also highlight that there is an urgent need to identify and treat underlying excessive alcohol use and alcohol use disorder, especially among younger individuals. I want to note that our study period did not include the impact of the COVID-19 pandemic, and multiple data have highlighted that harms from alcohol during the pandemic have only worsened. Our results may be significantly underestimating how many people will develop alcohol-associated liver disease in the future. Finally, our ability to screen for underlying chronic liver disease early before it progresses to cirrhosis is important, because if treated early, progression to cirrhosis can be stopped in the majority of cases. This will require collaboration within hepatology and gastroenterology, but also with a partnership with primary care and public health.